Hello, my name is Mazen. I'm a third-year cardiology fellow at Coral Health West, and I'm presenting a very interesting case today. This is the rare case of a patient with cardiac amyloidosis due to AL amyloid that presented with an inferior STEMI, and it highlights the importance of early diagnosis in AL amyloid, given the high rates of morbidity and mortality associated with the condition. This is a 60-year-old female who had a 6-month history of recurrent pleural effusions and dyspnea and was presenting to an outside hospital ER with acute onset chest pain. She did undergo EKG that showed an inferior STEMI as well as low voltage QRS and junctional bradycardia. She underwent an emergent left heart catheterization, which revealed a distal RPDA occlusion, which was deemed not amenable to PCI. She also underwent right heart catheterization, which showed elevated biventricular filling pressures and a low cardiac index. She was ultimately treated with TPA, heparin, and DAPT. TTE demonstrated an EF of 40 to 45%, moderate concentric LVH, and a speckle pattern concerning for an infiltrative process. She was ultimately transferred to our center for further management. We did obtain a cardiac MRI that demonstrated diffuse LGE of the basal segments of the left ventricle, which was highly suspicious for cardiac amyloidosis, as well as a left atrial appendage thrombus. Kappa and lambda free light chain ratio came back severely elevated at 30. A bone marrow biopsy was pursued and showed 10 to 15% plasma cells. After a fat pad biopsy was negative, cardiac biopsy was pursued, which confirmed the diagnosis of cardiac amyloid. The patient was ultimately discharged and began chemotherapy as an outpatient. In addition, an outpatient 14-day Xi monitor revealed paroxysms of atrial fibrillation. A few weeks later, she was admitted again with worsening heart failure and suffered a VF arrest in the setting of electrolyte abnormalities, and was ultimately discharged with a CRT-T device, and has since resumed chemotherapy and not had any recent cardiac admissions. So cardiac amyloid is a process that results in severe restrictive cardiomyopathy, which can lead to blood stasis, increasing the risk for development of cardiac thrombi, such as in this case. In addition, there's often severe biatrial dilation, which increases the risk for atrial fibrillation. And the combination of cardiac amyloid and atrial fibrillation puts these patients at very high risk for intracardiac thrombi. In this case, because of delay of diagnosis of AL amyloid, she ultimately developed a left atrial appendage thrombus, which can be seen in the top image on EGE sequence or early gadolinium enhancement sequence, and that subsequently embolized her distal RPDA, which can be seen in the bottom image, resulting in an inferior STEMI. In addition, several weeks after initial presentation, she suffered VF arrest, and this necessitated the placement of a CRT-D device, which, due to her junctional bradycardia, was recommended, as she would probably be pacing frequently. And it was also thought that it was important to augment the patient's cardiac output with a CRT-D device. Ultimately, this case highlights the high rates of morbidity and mortality associated with AL amyloid, especially in late presenting cases. Despite advancements in cardio-oncologic treatment, median survival has been reported as less than 1 year, although patients with early diagnosis and good treatment response can live much longer than that. In conclusion, patients with AL cardiac amyloid may present with cardioembolic phenomena. Care must be taken to make an early diagnosis, and aggressive treatment is often necessary to ensure survival upon initial presentation. Thank you for listening to my presentation.